Good afternoon, dear colleagues. I'm Alexander Kancsev and I'm a psychiatrist, and my PhD topic is the association between metabolic syndrome and cognitive dysfunctions in schizophrenia. Related to my vision is that I hope in the future schizophrenia will be a manageable condition and will be compatible with a fulfilling life. To achieve my vision, my mission is that I would like to fully elucidate the relationship between metabolism and cognitive dysfunctions in schizophrenia. Related to my PhD topic, we are currently working on two projects. In our first project, we are investigating the effect of impaired glucose homeostasis on cognitive functions in schizophrenia. In our second project, we are investigating the association between cognition, visual dysfunctions, and metabolic syndrome in schizophrenia. I would like to introduce you our first project. Some sentences about the background. Schizophrenia is a very severe chronic lifelong psychiatric disorder. The prevalence of the disease is around 1%. That means millions affected worldwide. The prognosis of the disease is very bad. These patients have 20 years shorter lifespan. 25% have a suicide attempt during their life, and they live with impaired functionality and productivity mainly due to the cognitive dysfunctions. To make the prognosis even worse, these patients are more likely to develop comorbid metabolic dysregulations and diseases. For example, the prevalence of insulin resistance in schizophrenia is 2 or 3 times higher than in the general population. And it is really important because diabetes is linked to worse cognitive impairment in schizophrenia, but this has yet not been shown for the beginning stages of the diabetic spectrum, for example, for impaired glucose metabolism and insulin resistance. So our aim was to investigate how the different stages of the diabetic spectrum affect the cognition in schizophrenia patients. We used the PICO framework. The clinical question was, is impaired glucose homeostasis a risk factor of more severe cognitive impairment in patients with schizophrenia? The population was schizophrenia patients, the exposure was the impaired glucose homeostasis, the comparison was the physiological glucose homeostasis, and the outcome was the cognitive test scores measured by an invalidated cognitive batteries or test. We hypothesized that impaired glucose homeostasis worsens cognitive functions in patients with schizophrenia. It will have many clinical and research implications. First of all, in their everyday practice, we have to use any available therapeutic options that we have. For example, we have to enhance the physical activity of the patients. We have to involve a dietitian to the treatment plans. And if it's needed, we have to use anti-diabetic drugs as an add-on therapy. On this slide, you can see the flowchart of selection. We ended up with 33 eligible full texts. And I would like to show you some results. On this forest plot, you can see the comparison between two groups, schizophrenia with versus without diabetes. To the left from the no effect line, you can see the studies where patients with diabetes had more severe cognitive dysfunctions. And to the right from the no effect line, you can see the only study where patients with diabetes had better cognitive functions. Even though we did not reach statistically significant findings, it's still clinically relevant because these results suggest patients with diabetes had more severe cognitive dysfunctions. On this visualization, you can see the two studies we found in the literature that compared schizophrenia patients with versus without insulin resistance. The two studies exhibited contradictory findings, so it will need further research to find out how insulin resistance could affect the cognition of these patients. Our study has some strengths and limitations. The strengths in schizophrenia research and in metabolic psychiatry, it's a large sample size. We investigated the data of more than 3,000 patients. And this is the first comprehensive analysis of the relationship between glucose metabolism dysregulations and cognitive dysfunctions. Also, our study has some limitations. It was very hard to pull the different cognitive tests together in a meta-analysis. And there are some confounding factors. For example, the antipsychotic medications, the benzodiazepines, the anti-diabetic medications could influence the results. Also, the compliance to the cognitive examination and the illness severity, for example, the length of schizophrenia and the length of diabetes. And our meta-analysis is based on observational studies. You can see our current status. We submitted our manuscript to the Journal of Psychiatry Research, and we are waiting for the first decision right now. In our second project, we are investigating effects of metabolic syndrome and its components on cognitive functions in schizophrenia. So as I mentioned before in the first project, cognitive impairment is a hallmark of the disease, and the schizophrenia appears to be associated with the metabolic syndrome diathesis, and it's importantly exacerbated by the antipsychotic therapy that we use in the everyday practice. And sadly, the metabolic syndrome and its constituent medical criteria are risk factors for more severe cognitive impairment. And here comes the question in a Hungarian sample, how can we measure the cognitive functions of these patients? For example, with the R1's cognitive battery. It's a really comprehensive cognitive battery. It consists of 12 subtests that provide 5 individual domain scores for attention, short and long-term memory, for language and for visual spatial skills. So our aim was to investigate the effects of metabolic syndrome and its components on cognition in this patient population. The clinical question is metabolic syndrome and its components a risk factor for more severe cognitive impairment in schizophrenia? We used the PO framework. The population was schizophrenia patients. The exposure was metabolic syndrome and its components, and the outcome was the cognitive functions in this study, the R1 scores. We hypothesized that metabolic syndrome and its components worsen cognitive functions in patients with schizophrenia. If our hypothesis is true, it will have many clinical and research implications, like in the first project, as we have to prevent the more severe cognitive impairment in this patient population. We have to think about schizophrenia as a multidisciplinary disease, and we have to involve other specialists to the treatment. We made a preliminary analysis after the enrollment of the first 155 patients. We collected the data from 3 Hungarian clinical sites. And I would like to show you some results from the clinical variables. We divided the patients into metabolic syndrome group and without no metabolic syndrome group. And as chronic low-grade inflammation is linked to schizophrenia and to metabolic syndrome also, we were interested in the interleukin-6 levels in the groups. And we found the statistically significant differences because patients with metabolic syndrome had higher levels in interleukin-6. On this slide, on this figure, I would like to show you some results also. With blue, you can see schizophrenia patients without metabolic syndrome. With red, you can see patients with metabolic syndrome. And with green, you can see patients with metabolic syndrome plus diabetes mellitus. And we found out that patients with metabolic syndrome plus diabetes mellitus had significant lower cognitive test results in the attention and delayed memory domain. After that, we were interested in the interleukin-6 levels in the 3 groups. We found out that patients with metabolic syndrome plus diabetes mellitus had the highest levels of interleukin-6. Interestingly, we did not find any differences in the CRP levels between the 3 groups. And after that, we wanted to calculate the correlation between the cognitive domains and the interleukin-6 levels. And at the top of the slide, you can see the significant negative correlations between the interleukin-6 levels and the attention and delayed memory domain. Our 2 study has similar conclusions and implications. First, we have to emphasize metabolic syndrome worsen cognitive functions. Type 2 diabetes mellitus is the greatest risk factor for more severe cognitive dysfunctions. Metabolic dysregulations must be prevented and must be treated as soon as possible, and multidisciplinary treatment is necessary. The implication for research is further studies are needed to evaluate or investigate the connection between metabolic syndrome, inflammation, and cognitive dysfunctions in this patient population. Here you can see our manuscript status. We finished the enrollment of the patients. We wrote the methods part. We would like to submit our manuscript to the same journal, hopefully in March. And I would like to finish my presentation with one of my favorite quotes. The key to happiness is not to get more, but to enjoy what we have and to feel the empty frame of our lives instead of enlarging it. Thank you very much.
Thank you for the presentation. It's very interesting. I just have one question, like in general, what is the common practice in Hungary or in your institution? Do the patients with schizophrenia get screened regularly for metabolic syndrome in order to prevent further?
Yeah, that's why we made this study, because the short answer is no. So yeah, this is our first conclusion in our first manuscript, that we have to screen the patients for metabolic dysregulations, and before we choose the antipsychotic therapy, we have to check the laboratory markers of glucose metabolism and dyslipidemia and so on, because the different kind of antipsychotics have different side effects, metabolic side effects.
Thank you.
So my question would be, maybe I didn't pay enough attention for your second project. Can I ask you how many patients were included in the study?
More than 200 patients.
More than 200. I think it's far enough for statistical analysis, isn't it?
Yes, yes, yes.
Okay, thank you.
Thank you very much.
Thank you, Alex, for that presentation. I, of course, am also deeply familiar with your topic, but I was just curious. So if you were to identify now a metabolic dysregulation in a patient with schizophrenia, what would you do clinically? What would you suggest for clinicians to do?
Yeah, for example, measure the fasting insulin levels, hemoglobin A1C, because it's not part of the Hungarian clinical routine right now. Hemoglobin A1C percentage, and so on. And if you find any disturbances, you can choose another type of antipsychotics. But for example, clozapine and olanzapine can induce insulin resistance like in 2 weeks.
Would you try to do any type of cognitive intervention specifically to stop cognitive impairment?
Yeah, cognitive remediation therapy it's a good tool, and you know, what I said is like we have to involve dietitian and physiotherapist to enhance the physical activity, because these patients live a sedentary lifestyle, so they are smoking. The dietary habits of these patients are not so healthy, I can say honestly. And the lack of physical activity is also a problem because of the negative symptoms of the disease. So yeah, that's why we need a multidisciplinary perspective.
All right, thank you.
Yes, I agree completely. It was a nice translational discussion now. May I have a question as well? Let's go back to this hemoglobin A1C. If patient with schizophrenia has a well-treated diabetes, can it have any effect on the actual cognition or not?
Yeah, it's a really complicated question, because, for example, the different kind of antidiabetics could also affect cognition. For example, we have data like, for example, metformin could improve the cognition of these patients, and also GLP-1 agonists. So it's really complicated. So many things could affect the cognitive functions.